Hello, listeners, and a warm welcome to Views on Health. A great pleasure, as always, to have with me back on the program Dr. Thushan Gunaratne, consultant vascular transplant surgeon at the National Hospital in Sri Lanka. A warm welcome back to SLBC and our studios, Doctor.
Thank you, and it's a pleasure to be with you once again.
Us too. And for the information of our listeners, the topic that Dr. Thushan Gunaratne has chosen on the program today is acute arterial thrombosis. Without any further ado, over to you, Doctor, to introduce the topic.
Thanks, Fatima. So I've chosen a topic that's not usually discussed in these radio programs and in medical public education, partly because it is not very common. Nevertheless, it's something that is very important in terms of saving people's lives and limbs. When it comes to vascular disease, there are two sort of emergencies that we talk about. One is if for some reason a vessel ruptures and there's a lot of bleeding that can't be controlled and the person can die from that. Another problem is that sometimes the blood in the vessels tend to clot and the vessels get blocked for some reason. We may remember a long time back we had a chat about DVT. There was blood clots in the veins. Today we're going to talk about blood clots in the arteries. So when you look at the whole circulation of the bloods in the heart, in the body, the arteries, the ones that take the blood that's pumped from the heart to the rest of the organs. So your brain, even your heart, your limbs, your gut, everything's supplied through these arteries. And in some instances, for whatever reasons, these vessels can get blocked. And each organ is made of tissues, and these tissues need blood supply to survive. And if the blood supply is cut off, then they basically die. So this is a topic I was going to talk about today, and later on we'll just discuss why it has become more important in current context, especially with the prevailing COVID situation, and also a little bit about some worries about vaccines that people talk about in terms of this arterial thrombus.
Thank you for that introduction, Doctor. And when you say that the tissues die due to lack of blood, the plasma that has flows, how does it happen? Because does it happen immediately when there is a lack of flow, or does it take a period of time?
So it's a very important question and a principle you brought in terms of vascularity. So each organ for the cells, they need oxygen, and the oxygen we breathe in is carried through the blood, through the vessels and into those tissues. There are times when it's a very slow obstruction. Those are not really a big problem in terms of an acute event. And what I'm going to talk about today is if it suddenly abruptly stops. And the problem is each tissue, each organ has its own threshold in terms of how long it can survive without that blood supply until the blood supply is brought back. For example, your brain, i.e. it's called a stroke, hardly can survive for more than a few minutes. After 4 or 5 minutes, the brain is basically dead. And the same goes to the heart. And the kidneys and the organs, the other organs, they have different times. In terms of legs and limbs, or the upper limbs or the lower limbs, you're looking at about roughly 6 hours, sometimes less, sometimes more, based on various factors. And unless you get the blood to those tissues within that time, basically you have to lose that organ.
So obviously it varies from organ to organ within the system, understandably. And so end of the day, when this happens, what happens? You're talking of acute arterial thrombosis.
So one of two things can happen. Either the blood that flows into the vessels suddenly clot for no reason, or else sometimes a clot that has happened somewhere else flows down the system and just blocks into a pipe. Just think of like the household tap or the drain. Sometimes a little bit of stuff gets blocked in the drain and it blocks. However, sometimes the water or the content is so thick and sludgy, it just doesn't flow. So the same two things can happen in any vessel. In terms of our vascular surgery, we are commonly involved in limbs, where the blood supply to the legs or the hands can get abruptly stopped, sometimes the gut, and sometimes other important organs like the kidneys. We ourselves rarely get involved in the brain and the heart, but the lower limbs and upper limbs are sometimes things that we are very much involved in. Usually, before the COVID, it was a case of a clot that's formed in the heart or somewhere else that just gets plopped into that vessel and blocks up circulation. And these are, like I said, acute events, and patients will present extremely agonizing with pain. The legs might become cold. The pale in color is very, very painful. The nerves and the muscles start to give up, and they might find that the leg, you can't feel the leg, you can't walk on the leg. And this happens over a few minutes to a maximum hour. Suddenly you find that the leg is cold and clammy and agonizingly painful. That's normally the common presentation that we get. And like I said, as to why this happens, commonly it is usually a clot that's formed in the heart, and these are patients who might have a predisposition for that. Either they have heart issues, the heart's not pumping as much as they should. You may have heard of a drug called warfarin, which is actually used to thin the blood in some patients who have heart valve changes, heart valve replacements, and if that warfarin hasn't been taken properly, you can get clots forming, and they suddenly come and block the vessels. So this is not commonly seen, but when it happens, it's an emergency, because we got a window in where we work in, and unless we can sort things out within that window, we basically lose the leg.
Doctor, how common is this amongst people? You said it's not that common, but then again, age-wise, is it prone to certain ages?
Not necessarily
or
ages.
Gender?
Not necessarily gender as well. It's more in relation to the disease they have had. So patients who have been on warfarin, who have been on what's called atrial fibrillation, where the heart rhythm is not beating properly. Some people got heart failure and the heart's not pumping as much as they should. And there are some people who's got a family history, a tendency for the blood to become very thick and sludgy, and the normal flowing mechanism is therefore stopped. And these are the normal sort of patient population, and those who have been involved in it usually have a family history or a past medical history that would predispose them to this condition.
So it cannot be actually pinned down to
not necessarily as such. There wouldn't be a gender or demographic population or subgroup that is prone to it. Why I want to talk about this today in this context is that this is something that we haven't seen often as common before, but with the pandemic and with the COVID, we see this more and more often, and a lot of papers and studies have been published as to the COVID disease itself can predispose to blood to become very thick and very sludgy. It can predispose to such a condition where the blood in the arteries get blocked. There's also a very high risk of blood in the veins to get blocked, and that can lead to DVT and pulmonary embolism, which we talked about some time back, where the lungs get blocked suddenly. So unfortunately, we've seen a lot of these patients who have had COVID, or who are having COVID, or who have been diagnosed with COVID retrospectively after we have seen them with the acute limb event. And there's been good evidence now that there's definitely a link between this acute arterial and venous thrombosis and COVID virus.
That's quite alarming, isn't it?
It is. I think luckily the evidence from Europe has come to us soon, and now it is common practice that patients who are having COVID in COVID centers, in COVID hospitals, they actually get a blood thinning drug to try and minimize that risk. But before this, quite obvious, suddenly we see 3 or 4 cases for a day when we normally see 1 or 2 for a month. Suddenly come with acute leg pain, the legs are getting blocked, the blood circulation is stopped. It's very difficult for us to manage these patients in those instances.
Doctor, what about the NCDs?
Yes, so
a relation with those, the non-communicable diseases, as and then this condition of thrombosis.
Yeah, I mean, so agreed. So things like diabetes, things like hypertension, ischemic heart disease, they will always predispose a patient to have a higher risk of blood clot formation, higher than the common general public. But I wouldn't want to mislead anybody to imagine that just because you have diabetes or hypertension, you're at a higher risk of this. The risk is still quite low. It's just that the combination of those medical problems might put you to a higher risk, especially with the drugs and things you might be on. And unless you have been having a different problem, or you have had chronic leg pain, the presentation of acute arterial occlusion is usually very, very clear. It's very clear cut. They'll often be able to tell it happened at this time. I remember I was just having a shower and poof, my leg suddenly gave away. I could feel the leg just dying in minutes. When I touched it, it was cold, it was clammy. I couldn't stand up afterwards. They were clear about that. It's just that I think in the current context, we got to be aware that this is more common, especially among the medical community. We are very vigilant that this can happen, and therefore a lot of mortalities with COVID might have happened because of either pulmonary embolism or acute arterial events like this that might have been missed, which is something I want to highlight as well.
So currently we are facing quite a serious situation with the COVID, and then you have patients coming in COVID, and then would at that point in time the hospitals also check on the patient's other conditions that may need to be, because the patient might not even say I'm diabetic or I'm this or I'm that, but maybe because the worry of COVID I think would surpass everything else. Then how does the hospital go into the patient's condition history?
Sure. So by the time we get a patient with this disease diagnosed with an acute arterial event, it usually takes a minimum of 3 or 4 hours for them to have either reached the hospital, then from the hospital to be seen by doctors, and to call the specialists like us who are not in all the centers, who are only in tertiary centers across the country. So by the time we get the patient with this problem, we diagnose them with acute arterial occlusion, we act fast. There isn't a lot of time and leverage to try and work at that point. It's a question of trying to unblock it as soon as we can and try to save the leg or the limb or the organ as fast as we can. The issues you talked about are usually stuff that then suddenly come up later on. Once the patient recovered, you got to check what his sugars are like. Does he have a predisposition for this? Has his heart been checked? Does he have heart failure? Is his rhythm good? Is he COVID positive? Sometimes you often do these surgeries without availability of COVID PCRs, or sometimes not even without a rapid antigen, because the time is so crucial in these instances. But of course, after that information is obtained, then we got to get back and have a chat with the physicians to try and sort things out.
Thank you, doctor. Going on from there now, in this situation, I mean, you did say that it's not gender specific or age specific, but would you say that the more older people would be more prone to this condition of acute arterial thrombosis?
I suppose compared to, unless a person had some predisposition between a younger person, a healthy person, and an older person, the older person may have a higher risk in terms of developing such an instance. But usually there is almost always a predisposing history towards this problem. What hasn't been clear is that there's also a young population who comes with this, and they have what's called thrombophilias, where they have a natural genetic background in their system that makes their blood very thick. So these patients who have thrombophilias are usually females, usually middle-aged. They may have had some history of miscarriages, may have had things called SLE or vasculitis. They are also prone to these sort of acute arterial events.
So either way, a combination of this condition and the virus attacking the lungs, the system, can be quite serious.
Absolutely. What is more worrying is that so if the patients who have had COVID and who have had these acute arterial events, they're actually healthy people, not necessarily people who have had those predispositions. So anyone who can get COVID, who would have got COVID, may be at increased risk of these, which is why nowadays we are very keen on making sure all these patients are given blood thinning drugs. And I suppose in the context of now we are moving towards a home-based management for asymptomatic patients, it's important that they keep active, they be hydrating themselves, do not stick onto a bed and just stay in a room without doing anything. It's important you move around, mobilize yourself, minimize that risk of having blood clots. And in instance where you do notice any of these symptoms, such as the excruciating pain, the change in color, coldness, some paresthesia and paralysis of that leg or limb or any organ, you should seek medical attention very urgently.
In other words, get to the hospital.
Absolutely.
So, doctor, practically, it may not be possible sometimes, because if you are COVID positive, you just can't get can't get to the hospital. There's a process of, waiting to, for the protocols to be followed, the health protocols that have got to be followed. Yeah. So in that time, what can they do?
I think what is important is informing the medical people as soon as possible, because you've got a window of time, either through 1919 or through the MOH or through the nearest hospital, so somebody is aware and they can start acting on it. If you already have various drugs that you've been on, for example, the warfarin, that is very crucial to make the blood thinning done at a particular level. You could make sure you take those drugs if you miss those drugs. Again, hydration. Make sure you keep yourself nice and hydrated, and that reduces the risk of blood stickiness. Apart from that, basically, it's a surgical emergency. So we need to see such patients as soon as possible to try and sort things out. I don't mean to give an impression that's a very common thing among COVID patients, but around 5% of patients with COVID have had these acute arterial events. So just be mindful and aware of all those symptoms and seek medical attention if it comes to it.
So how do you treat them in hospital?
In our case, there is very little place for medical management. The clot is there, we got to fish it out. It's a surgical emergency. We basically go in, we open the artery and drag out as much clot, thrombus that's stuck in those vessels, and we ensure we can get the blood to flow back again. Once that is done, then we will probably give them a drug called heparin to try and keep the blood as thin as possible. Unfortunately, if that window of opportunity is lost and the patient comes late, then we are not really able to try and bring the blood back to that organ, primarily because once the tissue has died, if you put blood back into it, all that dead metabolites actually get washed back into the circulation and can make you quite unwell. So in those instances, when the time is too late, in order to save the life, we may have to consider removing that organ. In case of a limb, that might be an amputation.
So may I ask you, in this situation of being afflicted with COVID, could you still perform surgery?
Yes, absolutely. COVID puts you at a higher risk of any surgery in terms of morbidity and mortality. So any elective surgeries are probably stuff that are not done for a patient who has COVID. However, if it's a life-threatening or a limb-threatening event, we often do these surgeries, and we still do, simply because the risk of not doing something is far greater than the risks involved in doing a particular surgery, simply because you're COVID positive. And most patients are recover comfortably in those instances.
So getting back to the question of you detecting, in the sense that you may not be the first person in your capacity as a vascular transplant surgeon seeing the patient. It could be some other doctor who would obviously have to refer. How does that process work at that point in time?
Yeah, so it's a very important question and important problem, because not all it's not all clear cut all the time. As in medicine, there's a lot of gray. It's not always white and black. And a lot of technique and skill and suppose experience required to try and diagnose it in difficult circumstances. In most 90% of the time, it's very clear. There's a clear diagnosis. The pulses aren't there, the leg is cold and clammy, and the patient gives a very clear history. When it's not so clear, then it takes time. And sometimes that may lead to the window of opportunity being lost. But it does happen, unfortunately.
This is a concern, doctor, because obviously the patients have been taken care of by other doctors, and then they have to detect this condition, or the patient has to, whether he or she can talk and articulates to sort of say, this is what I'm feeling, or this is what I'm going through, because otherwise even a doctor may not know.
Sure, absolutely. A lot of people are quite unwell. There are a lot of other medical problems that are probably prioritized at that moment, and these can easily be missed simply because the patient may be having difficulty in breathing or blood pressure not being controlled. So there are other reasons why they might be distracted, but once that is all cleared out, this will eventually come out. At times it might be too late, but often 90% of the time the healthcare system in our country is geared, and they are aware through programs such as this as well, to be aware of this condition of acute limb ischemia, which needs to be intervened emergently in order to save the patient's limbs.
So what is this window? You spoke of it at the beginning. Could you reiterate?
Sure. So for the leg, it all depends on each organ. For the lower limb, it's usually around 6 hours. If you're lucky, it might go up to about 10 hours. For things like the kidneys, it's different. The liver is different. Mainly patients present with leg ischemia or upper limb or hand ischemia. So for the leg is about 6 hours roughly.
So that is a bit of time that one has.
Yes.
But as you said, if it's like the brain, it can be much, much less.
Sure.
And the heart will be even less, on those
Yes.
grounds. So
Fortunately, those organs, they present very soon. With stroke or with heart attacks, they will go earlier. It's very clear. The legs and things sometimes are not very clear based on each person, each patient.
So therefore, the time frame that is there, it does help.
Yes.
Understandably, doctor. Thank you so much. Time is catching up with us. So is there anything else that you'd like to share with us?
Just one little small thing that I talked about. So a lot of controversy and concern about vaccinations leading to this sort of same thing. And there have been a few rare cases reported of some vaccines that have predisposed patients to getting blood clots, and people are worried. The reality is those risks are very, very small, less than 4 per million, for example, in some vaccines. Whereas if you don't get your vaccine, get this sorted out, the risk of having a similar thing, a blood clot from the COVID, is around 5 to 10%. So I just want to make sure, reiterate that it's very important you get your vaccinations done, and those slight concerns about side effect of blood clot from vaccines, I would disregard, because they're hardly significant compared to not getting it done.
So your take-home message would be get vaccinated?
Absolutely.
And anything else?
Be vaccinated, and just in case you're at home with the vaccine, with the COVID, unfortunately, if it comes to it, make sure you keep yourself healthy, hydrated, and be active.
Thank you so much, doctor. And on that note of advice, we end this very interesting discussion on acute arterial thrombosis. We place on record our grateful thanks to Dr. Thushan Gunaratne, consultant vascular transplant surgeon, National Hospital of Sri Lanka. Thank you so much, doctor, for being with us in the midst of your busy schedule to enlighten our listeners on this very interesting topic.
Pleasure as always.
Look forward to your participation soon. In the meantime, I hope that you will be able to carry out the good work you're doing along with your team, because we are facing trying times the world over.
Thank you.
My thanks also go to Tharindo Disanayaka for technical assistance. I'm Fatima Razikali saying good night and hoping to be with you next Monday same time on Views on Health.